So there were some questions. Sorry, I didn't have much time to answer questions last talk about the prevalence of dementia by age. So the slide had said 5 to 10% or 5 to 15%, I think, for 65. It actually is 0.5% at age 65, doubling every 5-year increments. Okay, so we're just going to finish off the first talk and the issue of HSV encephalitis. So as you can see on this MRI, there's quite a bit of swelling in and around the area of the anterior temporal and mesial temporal lobe on the right. So the presentation is very acute onset of short-term memory loss, altered level of consciousness. This is one of those cases where you don't want to miss it, and you definitely want to do an LP to see if you can find it. And the most common form is reactivation of HSV1, perhaps in the context of either critical illness resulting in immunodeficiency or some other cause of immunodeficiency. And it is unfortunately very rapidly fatal unless it's treated. So it is something that you need to catch. Investigations include the MRI, where again you can see this mesial temporal, anterior temporal swelling, edema essentially, and in extreme cases you can even get necrosis and hemorrhagic transformation of that area, and then the CSF as well. Just a caveat about the cerebrospinal fluid: if you are very keen and super astute and you catch the HSV encephalitis too early into the disease course, the CSF may actually be negative. That doesn't mean they don't have HSV. So a lot of infectious disease specialists will actually recommend continuing treatment with a cyclitor, that's the first line, for this if there is a strong clinical suspicion for HSV. And that's pretty much it. So Wernicke-Korsakoff syndrome, usually seen in the context of malnutrition, and therefore keeps company with certain other conditions such as alcohol use and pregnancy. And it's really targeting the mammillary bodies. And the result is this triad of acute encephalopathy, ophthalmoplegia, as well as gait ataxia, which kind of looks a lot like the Miller-Fisher variant of Guillain-Barré, but you'll have other risk factors and things to make it you think that there may be Wernicke-Korsakoff's. And one of the big sort of, so again, the mammillary bodies are affected. They become quite necrotic. You can see them hyper intense on the MRI. And one of the important things is that you can reverse this with high-dose thiamine. The other sort of dead giveaway that somebody has Wernicke-Korsakoff's, just sort of the bedside clinical pearl, is they will confabulate. People who have memory difficulties with Alzheimer's disease, they may actually, one, just deny that they have memory problems. They may just simply say they don't know. They might just stare at you blankly when you ask them for a recollection. People with Wernicke-Korsakoff will very happily give you something that's completely made up to fill the space. There we go. And they're very unaware of their own illness. The problem with Wernicke-Korsakoff's is that even after you give them thiamine, people can actually continue to have deficits lifelong. So it can be disabling. And you definitely want to treat it as a potentially partially reversible cause of dementia. And you don't want to have them then progress to having more significant symptoms, because they can actually die from this. So key messages: episodic memory, highly dependent on the function of the mesial temporal area, and that mild cognitive impairment subtype with amnestic predominant symptoms is generally the one that will convert to Alzheimer's disease given enough time. Dementia is distinguishable from MCI by function. Again, that's an easy exam question and answer. And Alzheimer's disease is the most common type of dementia worldwide. So I think that's pretty much it. The investigations, again, are very similar between MCI and AD. The MoCA is more sensitive than the MMSE. Part of the reason why you may want to do the MMSE instead of the MoCA is that it's just easier. You will overstress somebody who's into the moderate impairment range if you try to do a MoCA on them. So if you start doing a MoCA and they become flustered or they have trouble, switch to the MMSE. And if they have trouble with the MMSE, you may have to just stop. The main neuroimaging findings in Alzheimer's disease and MCI, again, is hippocampal volume loss. And the mainstay of pharmacotherapy are either cholinesterase inhibitors or NMDA antagonists. And the hallmark, again, are extracellular amyloid plaques and intracellular neurofibrillary tangles caused by tau. HSV and encephalitis, Wernicke's, as well as transient global amnesia, we talked about very briefly as parts of the differential for memory loss. And I'm not going to go over these again in the interest of time because we did at the beginning, and that's it. So Dr. Mitchell is away at the moment. I'm going to give you my email at the end of this upcoming slide set, and you guys are more than welcome to email me at any time. Now, are there any burning questions before we move on to the other talk? No? Okay. I will move on to the other talk, which is this one. Alrighty. Okay. Not all of the questions are activated on the polling, so don't worry. We'll just go through it together. Okay, learning objectives. Mostly to go over that approach that was outlined in Linda Lee's article. And part of it, too, is just to give you guys a good framework in general of how to approach people with cognitive complaints more generally. So by the end of this lecture, you should be able to establish presence of a cognitive impairment and characterize the cognitive pattern, and based on that, formulate a differential diagnosis and adjudicate whether or not there are any specialized investigations that need to be done in order to firm up the diagnosis. So on the right is the CFFM memory clinic model that was in your reading. On the left is just another sort of naturalistic way of approaching the history. So we'll go through this concurrently and together. At the end of the day, every single cognitive syndrome can be broken down into this sort of tripod of major features. As long as you can convey to your staff these three elements, they should be able to figure out the diagnosis with you. And as a physician in private practice or in independent practice, as long as you get these three things, you should be able to figure out what your patient has. Cognition is what we're going to focus on mostly right now. Function and behavior are a little bit beyond the scope of things, but those are other elements that you assess. So is there a cognitive concern? Again, this gets back at the NIA-AA criteria that Dr. Mitchell had in the first talk. You want to make sure that you confirm that there is a concern both from the patient as well as from others. So the patient is providing you subjective confirmation that there is a cognitive concern. Others are providing the objective concern. And one of the big differences is that when you're only restricted to subjective concerns, you're more likely dealing with somebody who's not as impaired. Now, this isn't going to be part of your exam, and I'm just putting it in here because it is going to be part of what you will see as you transition to clerkship. Subjective cognitive complaints is kind of the pre-MCI, and it's really only been a diagnostic category for the last 3-4 years. So most clinics may not even talk about it. But SCC is a concern because it is an at-risk state for MCI, which in turn is an at-risk state for dementia. So that's why we're talking about that now. Once you get other people concerned, so it's not just the patient now, but they have a family member, people at work who are worried about their cognition, then it transitions into essentially MCI. And the moment they can no longer work, or if they have significant functional impairment at home, that's when you transition to dementia. So we'll go through a case again, just like in the first talk. 51-year-old woman, Mrs. Dieter. Does anyone recognize the last name? It's supposed to be a dead giveaway as to what the diagnosis is. Okay, great. Okay, no history of medicine masters in this room. That's okay. Oh wait, I didn't look at Mrs. Saga. Never mind. All right. So 51-year-old homemaker. She lives in Munich, or lived in Munich, about 100 years ago. Difficulty with speech, and it came on very insidiously. And although there are, worse days and better days, she's generally speaking just sort of on this slow general trajectory of decline. There are no major fluctuations, is what I'm getting at. And her family physician, who's known her for a long time, notes that she's a little bit out of character in that she missed a few appointments. She never did that before, and she appears to be quite repetitive when she's actually in the office. So she seems unaware of these problems. The question is, are there subjective and objective complaints? So yes, there are objective complaints. No, there are not subjective complaints, at least not at this stage of her illness. So getting back to the model, from the reading, was the onset acute? No. Are there fluctuations? No. I made a point of that. Is there inattention? So it's hard to assess. You don't really have enough information from that stem, but you don't get a sense that distractibility is a major concern. They're much more worried about the fact that she's repetitive, the fact that she's having trouble with word finding. So there are actually other domains that are affected as well. And is her thinking disorganized, or is there decreased LOC? So these are all questions getting at, is this more a picture of delirium? And also, is there anxiety? So is she anxious? Is she irritable? Are there unexplained physical complaints? So a little bit more on the stem. She says that she generally feels okay, but her husband does note that there is some social withdrawal. The other important thing is that she's no longer doing things that she used to enjoy. She used to be a quote-unquote voracious reader. She withdrew from her book club. She's now doing a little bit of what we call self-censoring. And she just sits around all day watching television. And she was always very sweet, but now there are episodes where she seems to be a little bit upset and snaps at her husband. So yes, there is a little bit of anxiety. Yes, there is a little bit of irritability. So this gets at what I was talking about in the first lecture, where you can have what seem to be symptoms of depression, step 2 of the model, but that doesn't mean that you're necessarily out of the woods, although it might be. So is there objective evidence of decline? So the next thing that we can do is look at it with screening tools, again, introduced in the first lecture, MMSE and MoCA. Others, clock draw, like Dr. Friedman had just discussed with you. And then, of course, formal neuropsychological testing, which, as we had discussed, is very intensive, resource intensive, as well as just intensive for the patient. And it's very difficult for them. It's generally reserved for younger patients in milder cases. So getting back to her for a second, we do the MMSE and the MoCA. So she's a little bit more impaired than our architect, right? She scores 23 on the MMSE, and on the MoCA she only gets 20. Her clock is intact. So the question is there objective evidence that she's declined? The answer is yes. You look at the cutoff, she's below the cutoffs. What is the cognitive pattern? So this gets at why do we care about whether or not the patient has language issues, what sort of aphasia they have, do we think there's any frontal executive behavioral symptoms, do we think there are any memory problems? Because even though this sort of oversimplifies it, this is a good rule of thumb. Look at what the primary cognitive domain that's affected is, and that should give you a sense as to what disease you're looking at. If it's memory, it tends to be Alzheimer's disease. If it's visual spatial, it tends to be Lewy body or Parkinson's disease dementia. If it's executive, it tends to be vascular. If it's attention, it tends to be delirium. If it's language, remember, neurodegeneration tends to affect one hemisphere preferentially over the other, especially early on in the disease course. If it affects the left side, left frontal area, then you're going to get your primary progressive aphasias. They look a lot like the aphasias Dr. Friedman just showed you, except that there's more of that insidious onset and gradual decline that makes you think of a neurodegenerative process. And conversely, if it affects the right side instead, then you get those very bizarre maladaptive behavioral symptoms, impairment of social cognition that results in sort of the right side at frontal temporal dementia. So going back to Mrs. Dieter for a moment, just highlighting from the initial stem, 51-year-old woman, increasing difficulty with speech, so language. Pauses frequently, struggles with words. You just saw examples of that, right? She has an aphasic type syndrome. You may not formally diagnose her with aphasia, but she definitely has language issues. Missed several appointments, and she appeared repetitive. So from Dr. Mitchell's talk, she definitely has issues with her memory. So what domains appear to be affected? Those two. And what domains appears to be affected the most? So just a show of hands, because I don't think there's the Q response here. Who thinks, and this is Mrs. Haga as well, who thinks this is more of a language issue? And who thinks this is more of a memory issue? Okay, great. You guys sure you don't know the history behind this case? I'm just kidding. Okay, so this was her MMSE and her MoCA scores. As you can see, there are significant issues with recall, right? Long-term recall is affected. Her orientation is down. So you can tell that memory is definitely affected based on the MoCA and the MMSE. There are issues around verbal fluency, sentence repetition. So you can also tell that there are language issues. So the objective testing matches the subjective recollections of the patient and the objective observations of their caregivers, as well as your colleague in family practice. So this sort of reinforces the picture of what we're dealing with. So very importantly, is function affected in general? So again, that's important because it tells us whether we're dealing with someone who's more in the mild cognitive impairment stage versus somebody who's more in the dementia stage. Is there decline from previous baseline? You can get that from history quite easily. What are the instrumental functions that are lost? So instrumental functions, as you guys know, are the activities that allow us to exist in a modern society. Can we handle mail? Can we handle our email? Can we handle our finances? That sort of thing. Is self-care affected? Self-care is a much more basic function, so that's the activities of daily living, and those are generally preserved until much later in the course of disease. You can have preservation of ADLs and still have dementia. Generally speaking, you cannot have significant impairment of IADLs and still be in the mild cognitive impairment range. So IADLs is an early warning sign that you are heading down the road towards dementia. And the screening tools for that would be things like the ADFAX or the FAD. So those are just examples of it. And I don't know how well you can see this in Mississauga in particular, but again, ADLs are things like toileting, self-care, hygiene. Instrumental activities would be things like using the phone, etc. Some of these things can be affected preferentially depending on the dementia syndrome that you're dealing with. So that lady who was a teacher and drew the L on her student's forehead, because her frontal lobes are being affected, her ADLs may also be affected as well. So people with behavioral variant FTD, for instance, loss of care for personal hygiene is actually a major component of that. They may actually show up to the clinic and be malodorous, for example. So that's that. Now, going back to Mrs. Dieter, she was having difficulty with shopping and food preparation. She's no longer reading. We talked about that. And she rarely watches media as her disease continued to progress. And what's very interesting is that she missed a payment on her hydro bills and her phone bills. Didn't 100 years ago, but the case is updated. And she has trouble with her ADL. She's having trouble with bathing and self-care. So when her husband completed the ADFAX, her instrumental activities are significantly down. And he had additionally thought that her activities were fine, but that these difficulties with self-care began to develop later. So is function affected? Yes, it is. So going to the step 4 of the CFFM model, again, distinguishing between the different stages of neurodegeneration. We start with normal cognitive aging or subjective complaints. If there are now objective concerns, we knock it into mild cognitive impairment. If there are now functional impairments, then we knock it into dementia. And so that's really the question. What syndrome are we considering, given that her primary deficits are language and memory? And also, do we think she's MCI or do we think she's dementia? So based on all of this, what do we think is going on? Now, before we go to the actual question of the diagnosis, we'll go over the various domains and the localizations. And some of this is going to be review, hopefully. Major cognitive domains of concern. So for her, again, the concerns were memory. Okay, the definition, again, acquisition of new information, encoding of new information. Physiologically, primary localization is the hippocampus, the mesial temporal lobes, classically associated with Alzheimer's disease. And the key questions are, is there repetitiveness? So why is that important? If someone says that they're forgetting because they can't remember a bunch of people's names, that doesn't necessarily mean that they've forgotten their names. It could actually mean that they never paid attention to that person's name. In fact, if you look at people who have attention deficit disorder, name recollection is actually one of their biggest problems. They'll recognize faces and be embarrassed about the fact they can't remember a person's name, but they'll forget the name. If someone forgets to leave, if someone leaves the stove on, forgets to turn it off, if someone loses their keys, puts them down, that, again, doesn't necessarily have to be an issue with memory. That can be an issue with attention. However, if someone says something in conversation, a few hours later says it again, as if it were completely new information, that is more concerning for an actual amnestic decline. So repetitiveness is a major, major component. We do ask, of course, for misplacing. We do ask for whether they have issues with appointments and dates, and we ask them whether or not they're forgetting names, but that's less of a concern. Okay. Language. So that's symbolic representation of information. Primary localization is the left hemisphere. Dr. Friedman just went over all of that with you guys. And classically associated, when it's neurodegenerative, with primary progressive aphasia, of which there are multiple subtypes. And the question is, are they making those word substitutions? Are they calling the dishes day goods? And one of the things, just a clinical pearl caveat there, is that remember that the use of words is very regionally derived, right? So some people say car hold, not garage. Some people will say provisions, not meat and potatoes. So you need to be aware of the background of the person in front of you and not assume that they're making paraphasic errors when in fact they're just using the correct lexical key for the region they're from. Difficulty remembering names. Again, it doesn't have to be a memory problem. That could actually be a anomia, a language problem. And then are there problems with naming objects? So naming objects is much more clearly in the camp of language problems. Whereas forgetting names can be a memory problem, forgetting the name of common objects is very much a language issue. Visual spatial function is usually not volunteered unless it's bloody obvious, but it's very important to ask about. And really this is two things. One is the ability to perceive visual information, so object recognition, and the other is spatial relations, and that really comes out usually when you ask about navigation. Are they getting lost? Primary localization is the posterior association cortices, mostly on the right, and it's classically associated with the Parkinsonian type syndromes, of which Lewy body would be the most common neurodegenerative version outside of actual Parkinson's disease. So key questions on history: are they getting lost? Difficulty recognizing objects, and are they having difficulty recognizing faces? So again, people having difficulty recognizing faces, they're going to sometimes be said to have issues with memory. They're forgetting so-and-so. They haven't forgotten anyone. They just don't recognize the face that they're seeing, right? They're forgetting how to get to this place that they used to go to all the time. They're not forgetting anything. They just cannot navigate because their visual spatial function is down. So this is why the assessments in the clinic can be as difficult as they are. Executive function, again, I won't go into all of this again because Dr. Friedman just did, but task planning and sequencing, task shifting, judgment initiation, and self-regulation. Prefrontal cortex, subcortical white matter. So subcortical white matter is key there. Because executive functions are so tied to higher order brain function, any disruption to brain function or brain anatomy will lead to executive dysfunction. So one of the anecdotes that one of my senior colleagues has always mentioned is the human brain doesn't actually complete myelinating until much later in life. I don't know if you guys knew that. So one of the last places to myelinate is in fact our frontal lobes. And prior to that, our frontal lobes are partially disconnected from the rest of our brains. And so the anecdote that I was told is that women and men myelinate their frontal lobes at different ages. So any guesses on when, on average, female brains are finished myelinating? Who thinks it's before the age of 10? Okay, who thinks it's between the age of 10 and 20? Okay, you guys are mostly correct. So it's late 20s, or late teens, early 20s is when women's brains fully myelinate. So the question is now, when does the male brain finish myelinating? So who thinks it's before the age of 10? Okay, good. Who thinks it's between 10 and 20? Okay. And who thinks it's between 20 and 30? And who thinks it's between 30 and 40? Yeah, so it's actually early 30s. And so most men are kind of walking around as if they don't have a fully functioning frontal lobe until they're in their early 30s. And so this very senior colleague of mine used to joke that this is why guys tend to be very concrete in their thinking and why we like things and we're not in touch with our feelings and all that. Anyways, without getting too much into that, the reason for that is because of estrogen. So women, because of estrogen, the brain myelinates a lot earlier in women. Now, the sort of reverse is true when women undergo that change in their 50s or late 40s when you suddenly lose your estrogen tone. And women actually go through an almost pseudo-dementia in some cases around menopause for that reason. Men don't experience that usually ever, and if we do, it's in our 70s because as you guys probably already know, we get our estrogen from testosterone, right? Lectures from last year. Testosterone gets that big synthesis pathway that you had to do for the exam. So yeah, so testosterone gets elaborated into estrogen in males, and we don't lose our testosterone until our 70s, and it's usually a much more gradual decline. So anyways, that's executive function for you. Difficulty at work, trouble planning, multitasking, judgment, impulsivity, and restlessness. One of the big things about executive function is that it can be a lifelong issue. So again, ADHD is under-recognized. People with ADHD early in life, when your brain is going a mile a minute, are able to function fine. As you enter your 5th and 6th decades and you start slowing down, you're no longer able to keep on top of things as much. And this is again why people in their 50s and 60s often with a family history of Alzheimer's disease, come and are worried because whereas before they can remember their patients, now they have to refer to their notes and they're having trouble with the EMR. Those are all examples of people who are beginning to have issues with executive function. Executive function, again, because it is a distributed network function, it's not just a frontal function, is so vulnerable to literally everything. If someone has chronic pain, if somebody has lack of sleep, if somebody is using a substance, if somebody has another major medical illness, they are going to present with the dysexecutive syndrome. So this is going to be something that's very commonly seen. And a lot of my psychiatric colleagues will see this as well because, again, their patients are contending with illnesses of the brain that will lead to dysexecutive function. That's not me, is it? Is that a fire alarm? Does anyone know what that is? So that is impairing our collective executive function, just so you know. I will try to... Sorry, guys. Should we let's just continue. Can you guys give me focus on this? So the only thing that's sort of in your favor, just so you guys know, is for most people before the age of 30, your cognitive peak has a diurnal variation, and it peaks at around 11 o'clock, and it continues into 1 to 2. That's why most of us sleep in. And whereas the diurnal peak for people in their 70s tends to be in the early morning. Wow, this is really, really annoying. Okay, so my attention is not working very well. There is the slide. You can read it. I will send it out. But it's classically associated with delirium. So if you recall, one of the first slides Dr. Friedman showed you was serial sevens and months of the year backwards. That can give you... oh, it is an alarm? Oh, it is. Okay, never mind. We got to leave.